Good morning. I can speak with the microphone, right? Yes. So thanks for the introduction. And I would like to thank the organizing committee, Sandro, Carlo, Robert, and Peter for inviting me to this Congress. It's always a pleasure to be part of this community. So the title that I'm supposed to present is the POSORT guidelines, POSORT for POSEIDON Statement of Reporting Trial, Improving Study Design and Reporting of Clinical Trial. So what I will do in the next 20 minutes, I will actually go briefly on what you heard during these 2 days of conference, and I will also emphasize all the issues of the POSORT guidelines. So this is the POSEIDON criteria for low prognosis patient, and as you know, this POSEIDON criteria characterize patient with actually low prognosis or patient that have a reduced or very low number of live birth rates. And the objective of this POSEIDON criteria was actually to help delineating subtle difference in patient characteristics and to subgroup the patient to more homogeneous group of patients and to provide guidance for possible stimulation strategies. So we have these backbones of the critical backbones of the POSEIDON criteria, and actually you heard one whole presentation of each of the backbones. The first one is the number of oocytes retrieved or expected to be retrieved after a conventional ovarian stimulation with exogenous gonadotropin. And you can see a Polizio study that was actually every slide, or almost every slide, was presented in the previous presentation. So we really can see that pregnancy rate, live birth rate increase up to the 15 oocytes, and then there is a decrease. This is per embryo transfer, fresh embryo transfer. This is actually the result that were the same result that were presented by Shesh Sunkara. And here they also presented the cumulative live birth rate, and you can see here that as more oocytes are retrieved, the live birth rate is actually increased. So this is the first backbone, the number of oocytes retrieved. The second backbone is the ovarian marker, AFC and AMH, and again, you heard a whole presentation of each of them. This marker have overall good accuracy to predict poor or high ovarian responses, but they cannot correctly uncover the so-called hypo-responders. And you know that hypo-responders actually have a good ovarian reserve and low oocyte yield, and we concentrate also on this. And the last one is the female age, which can be regarded as a proxy to oocyte embryogenetic competence, giving the well-established association between age and euploidy. You can see here, or aneuploidy. As the age increases, the rate of aneuploid embryo increases. And this is actually the most predictive parameter for live birth rate in ART. If we're taking all these backbones together, so we know that reproductive success is mainly attributed to the number of euploid oocyte embryos. The more euploid oocyte or embryos, the higher reproductive success rate. And actually, the number of euploid embryos are included in the POSEIDON criteria. So where did this need to improve the quality of clinical studies using the POSEIDON criteria emerge? So since the introduction of the POSEIDON criteria in 2015, many studies appeared in the literature and that actually apply or related to the POSEIDON criteria. And we're looking deeply into these studies. You can see that there is a discrepancy concerning the reporting of clinical outcome. Every study reports a different clinical outcome. And more importantly, there was a failure to recognize the critical pillars of the POSEIDON criteria, the backbones. And this actually limits the clinical utility of these studies, because if they are reporting differently and they fail to report the clinical pillars, so there is a problem how to utilize this study's result clinically. One of the examples is if you are reporting of OPU and you are not reporting of the FOI, so actually how can you say that there is an improvement in that the intervention improved the outcome? In the POSEIDON, this is why the POSEIDON group developed guidelines based on the best evidence and expert judgment. And the aim of the guidelines was actually to clarify what to report in studies that relate to the POSEIDON criteria and how to report. And all of this was actually to improve the quality of studies using the POSEIDON criteria. Before embarking on or presenting the POSORT guidelines, let's also briefly discuss the endpoints. So this is the cumulative delivery rate. Sandro related to it a lot yesterday. So this is the definition of the cumulative delivery rate according to the International Committee of Monitoring of ART and also the MESHRE guidelines. This is the number of deliveries with at least one live birth resulting from one initiated or aspirated ART cycle, including all cycles in which fresh and/or frozen embryos are transferred until one delivery with a live birth occurs or until all embryos are used, whichever occurs first. This is actually this is the ideal endpoint that we all agree that this is the one that we should try to report, but actually it's difficult to report on this. Another endpoint is the FOI, the follicle to oocyte index. This endpoint was developed by the POSEIDON Society, and this is the ratio between the total number of oocyte retrieved following conventional ovarian stimulation and the number of antral follicle at the start of the stimulation. An intermediate endpoint, as Sandro called it, is the number of oocytes needed to obtain one euploid embryo, and this is why we use the calculator. And I want to suggest another endpoint, and the another endpoint that I want to suggest is an endpoint that will differentiate between two subgroups of the A subgroup. This would be the number of, it's only called the oocyte recovery rate. It will be the number of oocytes per number of dominant follicle on the DER trigger. Because if you get a very low number of oocytes with good ovarian reserve, if the number of dominant follicle at the end of the stimulation is low, so you have a problem with follicular recruitment and development. And this is the classical hyporesponders. This one needs or higher dose of FSH, or maybe the co-administration of LH. What's happened if you have a very nice recruitment, at the end of the stimulation you have these 10 follicles or 12 follicles, dominant follicle, and then 2 oocytes retrieved. In this case, this is not a problem of recruitment or development, this is a problem of abnormal final follicular maturation. This is where the dual double trigger came from, and this is where you have to use the double trigger, otherwise you won't actually overcome this abnormal final follicular maturation. And this, I did my day, because if I'm not speaking about the dual double trigger, I won't be satisfied coming back home. So I think that the POSEIDON criteria should also include this endpoint, because it is important when you're looking at strategies to improve the outcome of the oocyte yield. In those with high number of dominant follicle, it's not a problem of increasing the dose or adding LH, it's a problem of modifying final follicular maturation. Okay, so this is the endpoints. So you heard all this introduction, and this is why actually the POSEIDON group amended this guidelines development group, the GDG, which composed of clinicians and researchers with experience developing and/or participating in fertility clinical trials, and it's included POSEIDON and non-POSEIDON member. All the participants of the GDG group were given access to a relevant literature concerning the POSEIDON criteria. There were, at that time, 41 articles that related to the POSEIDON criteria, but you can see out of these 41 articles, only one article was an RCT, and the intention was to provide participants of the GDG with the POSEIDON criteria conceptual features and the existing evidence on its clinical use. The coordinator of the POSORT of this GDG used the published guidelines, already published known guidelines like the CONSORT, the IMPRINT, the SORB, and the GRACE. And they use this guideline as guidance to elaborate a list of items that will actually relate to the POSEIDON trial. And this is where the POSORT statement came. And the POSORT is the POSEIDON it's for the POSEIDON statement of reporting trial guidelines. So we have another guidelines now, the POSORT guidelines, it's actually related to studies that concern the POSEIDON criteria. The document of the guidelines was circulated among participants, and the consensus was achieved on items to be reported, which items and how to report the item, and also the endpoint that should be used in studies that relate to the POSEIDON criteria. The POSORT guidelines was published in the Frontier in Endocrinology, it's open access journal last year, so everybody can get an access to these guidelines. And here is a brief, actually the three tables that were presented in the guidelines. The first table is present information to be included when reporting article using the POSEIDON criteria. And you can see it's about 20 items related to when you are doing a study, so through all the way to the study, the introduction, what you have to report, when you are doing the material related inclusion, exclusion criteria, to include non-POSEIDON, POSEIDON members, the prevalence of them, if you are doing interventions, so how to present the intervention, the result, whether the study is observational or not observational, whether it's RCT or not. So this is the item that you should go over and try to include or implement in your study before conducting the study. Regarding the endpoint, so this is also the list of endpoints that the GDG suggested. There was consensus that the cumulative delivery rate should be the ideal endpoint to report, but you can report also the time to pregnancy or live births, the FOI index, percentage of patients who achieve the minimum number of metaphase 2 oocyte estimated by ART, and all other endpoints that might be used when you are dealing with studies that relate to the POSEIDON criteria. So what is the advantage of POSEIDON criteria in clinical trials? So we know that the probability of aneuploid or aneuploid embryos increase with age, and there is this 35 years cutoff that above 35 years, they're more than 50% aneuploid, and below less than 50% aneuploid. And also the association between the number of oocyte and cumulative delivery rate. So actually, these two statements or observations are included in the POSEIDON criteria, and because they are included, the POSEIDON patient, you can see that they have an overall lower delivery rate, low prognosis, and when you are looking at the subgroup of the POSEIDON criteria, you can see that also the prognosis varies according to the subgroup. And this is a study that was already shown in the previous presentation, retrospective study, including 17,800 patients. About 40,000 were non-POSEIDON patients, and about 3,500 were POSEIDON patients. And you can see the fourth subgroup. And we are looking at the cumulative live delivery rate of this patient. You can see that the cumulative live delivery rate actually differ across the subgroups. It's the highest in subgroup 1. Second best are the youngest with low ovarian reserve, subgroup 3, and then 2, that's the oldest with normal ovarian reserve, and 4. And you can see also that the non-POSEIDON group patient, those with good ovarian reserve, had a significantly higher cumulative live birth compared to the POSEIDON. So POSEIDON, if you're using the POSEIDON criteria, you can differentiate between those with low prognosis and those with good prognosis, and also the different subgroups of POSEIDON have different prognosis. Cumulative delivery rate in the POSEIDON patient is affected not only by the oocyte embryo quality, it's related to the age, but also by oocyte quantity. And as was shown in the study, female age emerged as impacting the reproductive prognosis more than the ovarian reserve and the number of oocyte retrieved. Group 3 has a better prognosis than group 2 because they were younger. Several considerations about biomarker. So if you're using AFC, try to use the criteria proposed by Borkman or Coelho Neto, how to operate the machine, how to use and what to measure. So that there will be some standardized measurement. Regarding the AMH threshold, remember that the AMH threshold in the POSEIDON was determined in 2015. It was ELISA. You heard a full presentation by Lamarca on AMH. You should realize that if you're using automated measurement, usually the levels is lower. And this is one study that was also presented here, a prospective cohort study of 178 women undergoing their first IVF cycle. You can see in this study, the mean AMH among poor responders was 0.74 nanogram, not the 1.2 cutoff of the POSEIDON. And when they did the AMH cutoff at 90% specificity for predicting POR and used the ROC analysis, so the cutoff was 0.93. So everybody should adjust the AMH cutoff according to their lab results, the local results. What about study design consideration? So having acknowledged the heterogeneity of the low prognosis group of patients undergoing ART, researchers need to focus on a well-defined subgroup of test-specific intervention. In this regard, the POSEIDON criteria are advantages in terms of providing a more homogeneous patient grouping. So actually, at the past, this is Politius' study. He looked at the definition of poor responders. So among 47 randomized trials, he found 41 different definitions. And then came the Bologna criteria. And if you're using the Bologna criteria, I believe that you will get at least 5 or 10 different subgroup of patients. So when using the POSEIDON criteria, you are using a more homogeneous type of patients. And this is important for when you are looking at intervention to improve outcome. Which kind of studies we should prefer? So we know that RCTs with participants prospectively and randomly allocated either to intervention or another following a strict inclusion and exclusion criteria is the best one to conduct. And there is the consort and the imprint statement that provided useful guidance to increase the quality of RCTs. The problem with RCTs is that are very expensive, and very complicated, and hard to conduct. And this is why we are mostly reporting on retrospective and observational study. Observational studies are actually reflecting the real-world practice. Most of our patients are not treated in a RCT frame, but they are treated as the real-world practice. This is why the observational studies may generate real-world evidence. They can generate hypotheses for testing in RCT, identify prognosis factor or patient baseline attributes to improvement or stratification. And if you are using the observational study, there are minimum standards that should be followed. You should try to avoid biases like performance selection bias. You should use balanced group, try to use homogeneous group, and this is why the POSEIDON group help you to use them, and you should adjust or minimize confounder, differential follow-up, and missing data. So observational studies are good, but you should need the minimum standard to follow. What about endpoint in the POSEIDON criteria according to the POSORT study? So the best endpoint, as I told you, was the cumulative delivery rate, but you can use also the number of oocyte retrieved, FOIS, the minimum oocyte needed to achieve one euploid embryo, etc. So all this list of endpoints that can be used when you are conducting studies that relate to the POSEIDON study. Of course, the ART calculator, a predictive model to determine the minimum number of oocytes required to obtain at least one blastocyst for transfer, and also estimate the chance of having an euploid blastocyst based on the real number of oocytes retrieved. I won't get into details, but Sandro showed yesterday the accuracy and the reliability of the calculator in a real-world practice. So what are the strengths and limitations of the POSORT guidelines? The POSORT guidelines were developed by an international panel of experts in reproductive medicine who reached a consensus on a minimum standard for relevant clinical trial using the POSEIDON criteria. The limitation of the POSORT is that the number of published studies of POSEIDON criteria is still limited, and the guidelines only represent the opinion of experts included, and patient representatives were not included. Nevertheless, the perspective provided in this consensus complement existing guidelines, the consort and others, and may help advance knowledge, potentially improving treatment outcome. If we should conclude, so the guidelines was developed to improve the quality of reporting in clinical infertility studies using the POSEIDON criteria. It did so by better characterize the study participant, more homogeneous group to study, reporting clinical endpoint relevant to the POSEIDON framework, like the FOI. And therefore, actually, by using these guidelines or implementing the guidelines to your clinical practice, you promote complete and consistent reporting to advance knowledge concerning the POSEIDON criteria clinical utility.